Okay, we're waiting for one more person to join us, Dr. Badani, right?
No, I think you're waiting Dr. Karl, no?
He's the speaker.
Yeah.
Hi, Dr. Mary.
Arun, we can't wait. We need to start on time. Please start introducing the chairpersons.
Yes, sure. Thank you. Welcome, everyone, to the session on clinical excellence in palliative care. So today with us, we have Dr. Shiv Iyer, waiting for Dr. Badani to join. And we have speakers with us, Dr. Meera Agar and Dr. Marian Mukherjee. So I'd like the chairperson, Dr. Iyer, to introduce the speaker first, and then maybe we can start with Dr. Agar and then go to Dr. Marian Mukherjee. Thank you.
So, Arun, who is the first speaker?
We can start with Dr. Meera Agar, please.
Dr. Karl is your first speaker, Arun.
Yes, we have Carl with us. I think.
But he's not joining.
Carl is not.
Yeah, he's joining. He's
He's joining. Okay. Okay. Then we can start with Dr. Lawrence.
So I do not have their CV. So
we have it on the preview.
So it will come up on the screen.
I guess so. Is there on the preview?
So when it comes up, then I'll introduce him.
He's joining. He's joining.
Sorry, I had tried to join earlier, but I think for some reason it's the wrong link or something. I can't with my I have a camera, but I'm that one. You can't. Others though.
We can hear you consistently. Your voice is between.
Dr. Shiv, the
Yes.
Karl CV is on the preview. You can read it from preview. It's in front of you.
On the preview. You mean? You mean the preview that you sent us on the mail?
Should I read it out?
Yeah, please,
Yeah.
Go ahead.
So Dr. Karl Lorenz, welcoming you to this 29th International Conference of the IAPC. He is a primary care and palliative care physician professor at Stanford University with 20 plus years in palliative care, and his areas of interest are quality of care, quality improvement, and health services research. For palliative care team across India for the last several years. Dr. Karl will speak on a topic of clinical excellence. The next speaker after Karl Lorenz is Dr. Meera Agar. May I see her slide, please? Professor Meera Agar is Director of Impact Center. She works in Sydney in the University of Technology. She has 20 plus years of experience. Her areas of interest are palliative care, delirium, clinical trials, older people with cancer. Achievements are she's the chair of cancer symptom trials and chair Palliative Care Australia board. Our third speaker is Marian Mukherjee. Dr. Marian Mukherjee is the professor and former head of department palliative medicine at Tata Memorial Center, Mumbai. She's a medical lead at Sukoon Nilay, more than 20 years of experience. Areas of interest are palliative care of cancer, pediatric palliative care, integration of palliative care into the trajectory of illness, more than 100 publications in national and international index journals. May we have Dr. Karl's video now, please?
Hi, I'm Dr. Carl Lorenz. I'm a professor of medicine at Stanford University and the VA Palo Alto healthcare system, where I also serve as section of California. I'm really pleased to be with you this morning to talk about clinical excellence in palliative care, and specifically, how do we achieve clinical excellence? I have three objectives that'll hopefully shed some light for you on that topic. The first question is, what is quality improvement? I believe it's curiosity, humility, and a recognition that the current state of the care we're providing a lot of questions, involve stakeholders, and include diverse, even overlooked individuals. And what can we learn from an example of quality improvement? I'll show you that quality. And next slide. So let's begin with an example. Would you go to the best doctor at the worst hospital? Or would you go to the worst doctor at the best hospital? I think probably not, because doctor couldn't function as the best doctor in the worst hospital, especially if it looked like that. And even in the best hospital, you couldn't receive the best care if you were taken care of by the worst doctor. My point is really that there are two aspects to challenges in quality. Next slide, please. Quality isn't just about failed people. This is just an example of the case of a person delayed by a train wreck somewhere else in Los Angeles. This is a picture of the complex train system that operates in Los Angeles. And sometimes when you're waiting in your car for something to happen, the delay is actually far away. That when we see a quality problem, there are often underlying issues at play that are often far removed from what we can actually perceive. Next slide, please. And fundamentally, the reason that both people and systems fail is that they're designed by people, and people sometimes make mistakes. We also are different, and so we design systems differently. And sometimes we don't design mistakes in, but because systems are complex, even good choices can lead to problems. But the underlying issue is that we're all different, even those of us who look alike and sound alike. And so we'll always design things just a little bit differently if it's up to us. And so in complex systems, we have to understand that there are many reasons that things fail. Next slide, please. And this slide is meant to show you that even when quality is good, isn't always bad. And this is a report from a large healthcare system in the United States, just showing you that when we measure outcomes and processes related to quality, you can see from the height of the graphs under the different bar graphs that the rates of doing things that we consider necessary vary significantly. And like the facilities in the lower left-hand corner show you on this slide, not only do the actions we take vary, but they vary from site to site. So variation is a normal part of healthcare, and sometimes that variation leads to problems in quality. But in general, the question is how we can reduce variation and push ourselves towards better performance. Next slide. The journey to better care, the journey to excellence, the journey to reduced variation starts with asking just variation that we wish we could reduce. The first did that happen? And why did that happen? And experience shows that we can continue to ask that question until we get to something called the root cause, which you see down here at the bottom, which is really the basic and underlying problem that we'll need to address. Next slide, please. And problems in quality, challenges generally come in three categories. When we look for quality problems, they will raise their head as either outcomes. These are things that we see, like patients don't have a good experience in their care. They aren't satisfied. Identified a problem, and we thought complex problems are too big for one person to see. A perfect example is how a person might describe an elephant if they could only look at a small part of it and we're standing in a different place, and ensure the policies that need to change to monitor and sustain a solution are part of solving the problem. And we want to pick people who are respected by others, because we can't include everybody in solving a problem. But when people know we're trying to solve it and they respect those who are involved, that will help. Authoritative and influential voices within the organization as part of our team is also important. Next slide, please. But another important lesson is not to restrict ourselves to including important people. We also want individuals who have a stake, and those individuals aren't always important and they don't always look like us. At the center of this group is the patient. And how often do we include patients in problem solving? Others represented in this group are individuals who are diverse because of their race, their ethnicity, their gender, but also individuals who have seemingly a lesser role in the work. And when in the early case of Elizabeth Kubler-Ross, when she was trying in the 1960s to bring attention to death and dying, her first advocate, her first partner in change, was someone who worked as a cleaner in the hospital. A very humble role, often ignored. And why was that person influential in Elizabeth Kubler-Ross's work? Because they were the ones who spent more time at the bedside of the patient than anyone else, changing their bed when it was soiled, working to keep the room clean. And they often had the time to speak to patients and understand their problems in a way that many of the physicians couldn't. So we should include diverse individuals in our groups, and we should include people who are otherwise overlooked. Both of those things will make our efforts to solve problems better. Next, please. So next, I'd like to give you the example of what it looks like to solve a QI problem. And this is using the example of learning steps in a project conducted at Ames. The first thing is to ask a question, to ask the right question, to set the right goal when we've identified a problem. We call that a SMART goal. And SMART goals are specific, they're measurable, they're attainable, they're relevant, and they're time-based. In the case of Ames challenge, the target they set for themselves was to decrease the time between registration at a head and neck cancer clinic and referral to palliative medicine for advanced oral cancer patients, and reduce that time from 50 days to 10 days in May of 2018. Next, please. After you've set a goal, the next challenge is to collect information about that goal, to realize what the current state is, so that when it changes, we can recognize change. And this is an example of the data that was collected at Ames that helped them define the problem. This was the measurable part of their goal. And they were able to show that the average days to referral were 50 days when they set out on this project. Next, please. The next step, which we've talked about in terms of the 5 whys, is to think deeply about causes. This is what the group gives to you when you sit people down together and ask them to think deeply about the problem and its causes. We tend to group these in a fishbone diagram into these 6 categories, which you can see: measurement, materials, environment, method, people. And these are put in a diagram that shows how they relate to each other. So, so this was a fishbone diagram that the group used to understand potential contributors to the problem of delayed referral. Next, please. The next step is to analyze those underlying problems. And so here, they're organized in terms of those 6 categories. The causes then, which were on the diagram, are under the causes. And the key drivers are the underlying issues that relate to the cause of those problems. For example, cultural understanding of early referral and symptom management by the team was believed to be driven by the lack of education for the staff, the oncology staff, about the palliative care consult team and what their relative roles and processes were. So that was one example, but also there was not a process. Another key driver was there was not a process for palliative care referral and consultation. And the causes, which were obvious, where there were no standard guidelines for screening for symptoms, no tool for screening, and the absence of the symptom burden being charted in medical records. So, so the causes then are mapped to these key drivers. And next slide. And then provide the basis. Well, let's see, I'll wait a minute. You can keep going. You'll need to get to the next slide, please. The key drivers, recognizing them, then gives rise to the interventions. So for example, where the key driver was the need to determine a process for providing palliative care referral and consultation, the way to fix that was to include a symptom burden on the chart in the head and neck clinic notes, and to come up with a process and guidelines for how to screen the patients and refer them to palliative care. And you can see there were a number of other interventions that were used then, each of which maps to one of these underlying reasons for the problems that were identified. Next slide, please. And here are the examples of the interventions. So to help the oncologist understand palliative care and how palliative care could be helpful, a pamphlet was created. And this was intended to communicate to the oncologist the value of palliative care. Education was also provided to the oncologists in regular meetings, and this changed their attitudes and their willingness to work with the palliative care team. Next, please. A referral protocol was developed. And so again, with the agreed upon stakeholders in both groups, they developed a process for agreeing on how palliative care could be better involved, excuse me, and more routinely involved in the care of patients with significant symptom burden seen in the head and neck clinic. Next, please. And finally, they developed a charting approach. And here is the symptom burden chart, which was placed in the record, excuse me, of head and neck patients who were being followed in ENT. Excuse me. Next, please. Finally, after these interventions were instituted, you can see that the days for referral for advanced oral cancer patients dropped. And as they were implemented, average days to referral decreased from 50 days to 14 days. Aren't achieved, then often the cycle is repeated. But when it is achieved, then the next step is to think about sustainability. And these are steps that the team took, excuse me, to foster success over time and to ensure that the gains that were made would be lasting. And so they continued to educate providers and to make departmental meetings to ensure that both staff, faculty and residents continued to be aware of their protocols and the approaches they were using for collaboration. Next, please. Finally, they took an important step, which is sharing their findings with others. And this allows others to learn from the experiences we have in quality improvement and can spread the success then elsewhere. Next, please. So I'd like to close widely, including palliative and end-of-life care. And it varies because humans vary in their perspectives, sometimes making errors, but sometimes it just varies because we make different choices. We need to learn from that variation. And when we see a problem with care, solutions start with asking why, but then asking that again and again. In summary, we can follow a systematic stepwise approach, much as the AIMS team did, and learn from others who are championing quality improvement in India. For those of you who are interested in this topic and would like to know more about it, I'd suggest that you reach out to Dr. Nandini Pillai, who's the director of the QI Hub India and Project Equip. Further information can be found at the URL that's provided on the final slide. Thank you for letting me share a little bit about the journey of quality improvement.
It's a pleasure to be presenting today in this session on clinical excellence. The topic I'm going to cover today is the role of connection with our patients and how that contributes to achieving clinical excellence and our lifelong learning. I'm presenting from Sydney. I'm on Camaragal land and I pay my respects to Indigenous elders past, present and emerging. So why does connection with our patients influence clinical excellence? We know from the literature that organisations which are more patient-centred also have more positive outcomes. It not only improves the patient experience, but the quality of care improves, healthcare costs decrease, and provider satisfaction increases. So what are the dimensions that we're considering when we're thinking about person-centred care and how it can contribute to clinical excellence? We're talking about respect for the person, emotional support, physical comfort, information and communication, continuity and transition, coordination of their care, involvement of their family and caregivers as they wish, and access to care more broadly. And as you can see, these are all elements that are very critical to holistic palliative care. So this is a quote from Diane Meyer, and I'm going to read that to you. All of my patients are living with profound fatigue, pain, shortness of breath, financial and family stresses, and mountains of worry. How do we then achieve the greatest value with this effective care, giving patients neither less nor more than what they need? We start by asking patients and their families what matters to them, not focusing on the disease alone. We recognise that for patients with serious, progressive, usually chronic conditions, as their illness evolves, what matters to them and their family also changes. So one of the important things, if we're thinking about how we drive this aspect of clinical excellence in our teams, in the people we train, and in ourselves, is our students or our own sense of purpose, achievement and significance, then this will be the dominant value that we hold. And sometimes I think it's this credibility of patients' knowledge or the lack of legitimacy. It's really around power relationships, and we need to be able to challenge those up front. The other important thing, and this is where us roles as specialists in palliative care become really important, is to provide good role models. And this student quote, I think, really highlights that we have made significant improvements in making sure that in undergraduate training that we are thinking about how to train people to have difficult conversations. But students are saying that this is disconnected from what they see in their clinical work. When you first have a patient who is dying, you avoid talking about it because you don't have the words and don't know what to say. The other narrative is the no time narrative, and that emotions and connecting with patients is time consuming and you risk your self-preservation of professionalism in a busy ward. And this quote really illustrates that. A message that there isn't time to listen to a person's story. Further, they are learning that getting emotional or close may actually be seen as dangerous, especially when it puts self-preservation at risk. This strongly articulated message that an experienced physician shouldn't or doesn't have time to show emotion. So what are the mechanisms by which we can drive improvements in person-centred care? So an important way is ensuring that we have role models and have capacity to assimilate those role models into our own practice. Both for our fellow clinicians, but also the people who we are responsible for teaching. We need to make sure people in our team feel welcome, safe and secure to be meaning making related to those stories, and continue to be comparing, combining and broadening our perspectives about the experience of living with a life-limiting illness. So one of the things we need to be aware of when we're striving for clinical excellence is the things that we learn or our students learn without anyone teaching them. Now, what are the unofficial rules of the clinical environments in which people adapt and adopt because they feel that it makes them more easily accepted into this social group? Are we changing our behaviours to align with the more senior members of the profession to become part of the team? So one of the things that we need to all have and continue to develop if we really are truly going to be leading in our clinical excellence is our narrative competence, our capacity to hear and interpret our patient stories. Clinicians who are trained in narrative medicine strengthen their ability to comprehend and put to clinic use all that their patients tell them, whether that be words, silence, gestures, physical findings, images, and through the clinical relationship itself. We then gather an increased understanding of the pivotal importance of outcomes of care, of who the patient is, who the clinician is, and the dialogue between them. And quoting Jeffrey et al., that precisely the moment when two people share feelings of uncertainty, vulnerability and loneliness, that dialogue is most possible between them. So moving on to then clinical judgment and how this conversation can also help us in our clinical practice. Something that we teach our postgraduate students in our palliative care programs, and it's being developed by Professor David Currow that many of you may know. So the first thing, a person has a life-limiting condition. We need to be determining whether this is an expected or unexpected deterioration. What can we do about the problem? And what are the patient's wishes at this time? And what are the family preferences or goals of care? So let's explore the why framework in a little bit more depth. Today because of an overall progression in treated disease? Or is this person unwell today because of the effects of an acute problem with an easily reversible cause? And then the sub-questions around that is, why has a change of condition occurred? What's the time frame for the change? What else has changed around the same period? And can we do something about the problem? And even if the answer to that is yes, we could do something about the problem, that doesn't mean we rush in to start treating. Think about the likelihood of reversal and the person's wishes under this circumstance. We're often tell us and what's happened before they presented to the clinic at the time that we're talking with them. And if we don't listen to the story about the context and the wishes and preferences of that person, our clinical judgment decision making is not going to be positioned within the life story of that person. So are these things that we can measure? Now, can we use the connectivity and the person-centeredness of our approach to care to actually drive improvement? So one of the things we're increasingly understanding is the role of patient experience measures. That these are important ways that we can assess and understand the impact of our services on patient experience, and an important way that we can actually monitor person-centeredness and improvements. One of the things that I attend in my hospital is the morbidity and mortality reviews. And often the focus of these reviews is to look at it from the preventable death perspective. What could we have done to save this person's life or allow them to live a bit longer? But we've increasingly, as the palliative care team, looked at what could have been done to ensure that this person had been more comfortable and their symptoms had been managed. What did we know about the person's preference, and was the treatment that they received aligned with those preferences? And using the why framework questions in the morbidity could be a really important way to make sure that the care that people are receiving at the end of their lives, whether it's a predictable or even the unpredicted death, was based on the wants and needs of that person. We can think about 360 reviews. That's getting the opinion and feedback of our peers from a whole range of disciplines around us, the whole team around us, about our professional practice and really thinking about where we have opportunities to improve and are we truly acting as the role models that really can drive improvements in care. One of the things that we really don't have much focus on in our continuous professional development is communication skills training. We need to be thinking about this as important as we update our cardiopulmonary resuscitation credentials on an annual basis. Now, what are the skills that we feel we need to think about, reflect on, and have experience in terms of our communication and connection with patients that we can continually grow? So hopefully that's given you a little bit of a sense of how connection with patients really is critical to clinical excellence, and some of the ways where we can really embed that into our health systems, our health services, and our own professional development to drive excellence in clinical care.
Good evening. Good evening, friends. Thank you to the organizers for giving me this opportunity to talk to you a little bit more on clinical excellence and how can we grow, especially for India. What is my learning plan? Probably in this next 15 minutes, we'll talk about the definitions both in the US, in the UK and Canada, and then see how we started in India and then how are we going to take this forward and what way can my organization help in this. I'm sure you've seen this many times, so it's just a revision of what the US thinks about clinical excellence. Right on top, there is communication, which I think is really, really the most important part with the partners, with the patients, when dealing with patients, superior clinical judgment, being organized and efficient, and always keeping in mind that need for professional growth and development. In other words, no stagnation. And while we are dealing with our patients, we need to be professional and realistic. Is it any different in the UK and the Canada? Not really. In the UK, there's something very interesting, and that is they have these awards, which are cash awards. So if you get yourself accredited by doing a high quality service, leadership, research, teaching, then you will get 5 years award of clinical excellence, which you can renew. And if you look on the right hand side, I think Canada is also saying the same thing. Professional activities, we have to teach the residents, the public, other professionals, take all that evidence, put it into practice, keep on creating and disseminating that knowledge. What should we do for India? And I agree chance to take this forward, maybe. If we know that MD, and we are hoping to have a DM very fast in pediatrics. And if we are going to be an alternative to all those treatments which are happening to our that clinical excellence, we need to have our SOPs in place so that they will understand that we are a very good alternative to taking care of that thing. I think today that this is a life have to take on in the areas of service, like we are going to have to look is a very good alternative integration. We will develop our superior clinical judgment testing our geriatrics, nephrology, neurology. So that in this, there is essential components and desirous components. So the work was done and it was published in the year 2014. The program called Quality Impact to happen from which is stopping here, but it is something which in taking quality the essential elements and the design. You can see in this slide the also the training for the staff, training for self-care. Administrators, and they do have research and advocacy. Being about what the Indian Association of Palliative Care doing is the same thing which we have been talking about services by having those audits very important for our hospitals. Well, any those standards, but whether can we improve clinical excellence? Same thing in the service. Improving that quality of life. Set up. Dr. Ruth has set up neuropalliative with name hands. We are setting up the group for feedback for anybody who asks for a have audit cycles well. GPs play such an integral role. Let's bring them also into our quality improvement and to a process of clinical excellence. Palliative care, or whether you're in the specialist field, for all the cadres, let's keep doing our audit cycles. Let's take help of IAPC for those desirous elements to improve. Let's use Equip India, which is for oncology. Should we have awards in our training, in the training that we do, and we all do it. I know each and every one of us has some form of training. Let's improve our training components, because when you're trained, it's work oriented. And as this was given to me by my colleague Arun, just in time teaching is all about using your available clinical experience, and probably that's what we use all the time. Let's keep doing it. Let's keep having those lifelong efforts at teaching. Let's have research. Let's have advocacy to help of clinical excellence. And some other things which we would like to hope to put into place, as I which should be part of clinical excellence, is ready to take a role in this. Sukun Relaya is ready to take a role in helping in patient safety and continuous quality improvement. And as the Indian Association of Palliative Care, I think very hard in having those NABH standards made mandatory. I'm not sure if they already are, but if they're not, then let's IAPC, let's all join. But learning, it's personal development and growth. It's personal reflections. So those personal make it collaborative. Let that be our take home last message. Let's all collaborate to learn together, teach together. And once we've done the learning together and the teaching together, probably what we will then continue to do is to do that research together and put out in renal the whole group of papers by the Manipal group, put it out to use advocacy. And we will be able to bring home maybe another 20 publications, which will be a method of advocacy for us to bring clinical excellence into our and cancer palliative care into the world of our patients to make life much better for your patient listening. And I'm pretty sure that there would be questions which we are happy to answer.
Thank you, Dr. Marianne. We've had 3 excellent slide which Dr. Lorenz had put up at the end. They should be able to get that. So thank you, Dr. Carl Lorenz. Then to focus on, and I think it is extremely important if from the puzzle solving session, better health, better quality in health. And then, of course, we had Professor Marianne Makaran at the end about the Indian scenario and the creation of a Indian Journal of Palliative Care, NAPH, Introduction of Standards. But also is how will some of these quality improvement projects. If there are Professor Carl's email.
If there are any questions, we can probably take it and
In an excellent, I think all 3 speakers have stressed it is about how you look at and not be satisfied and let your inherent curiosity drive the need for clinical excellence. So I think if there are
yes, thank you very much. Big clap for our
really enjoyed the sessions.
take care everyone. Have a good day. Bye bye.
Okay. Thank you very much. Over to Anjum.